All right. Good morning, everybody. Thank you for joining the North Carolina Partnership to Address Adult Abuse. This is our general meeting for September, and we're glad to see everyone. Hope everyone is staying safe out there, and we hope you'll really enjoy our presentation today. I believe you will. And I just want to remind everybody that it is time to send your membership money in. You can find membership applications on our website at ncp3a.org. And you can pay by PayPal, you can send a check in, however you want to do it. But we encourage you to go ahead and get those memberships in. Now I'm going to turn it over to Laura Slobach, our secretary. Laura?
Hey there, good morning. I'm just going to, well, actually, I don't think I have the ability to share any longer, Allison. I'm sorry. It was there and now it's gone.
You should have it now, Laura.
Okay, yep,
Okay.
perfect. All right, is that showing the minutes from July 21st?
Yes.
Okay, there's two documents open, so I wasn't sure. Perfect. So we had our last general member meeting on July 21st. Tadra and Larkin and Luke from Disability Rights were our presenters. And I'll just scroll through it. If anyone sees any corrections, I'm happy to do that. Tadra and her team gave a really fantastic presentation on guardianship. And folks with DRNC did a great job.
Does anybody have any corrections to the minutes? If not, can we get a motion to accept and approve the minutes?
I will so move. And
Thank you, John. Second?
This is Nancy. I'll second.
Thank you.
Awesome,
Laura,
thanks.
did you have anything else for us?
Nope, that was it.
Good, thank you. All right, now we'll have our treasurer's report. Pam Palmer?
Good morning from Iowa. We started the month with a bank balance of $18,900.85. We have the $3,000 in the reserve, so our beginning balance was $15,985. 985 cents. We had membership dues, organization 250, individual 125, student and individual 30. We have total membership of 405. We currently have 5 organization members, 5 individual members, and 3 individual members that paid this year. We have 8 individual total members that we had 3 that paid prior to the year. So that's why the discrepancy in that. For our expenses, the new expenses since the July 21st meeting, we had a post office expense of $204. We are paying a sponsorship for the Coalition on Aging meeting, $154.50, and additional $1.81 in PayPal expense, total expenses of $459.40. We have a balance currently of $15,846.45.
Thank you, Pam. Does anybody have any questions for Pam on the report? Okay,
And
if not, can
updated
we get a,
membership Lists are on the website under membership if you want to see.
yeah, thank you, Pam. Does anybody want to make a motion to accept the treasurer's report?
I will so move.
John Marin, thank you. Second,
A second.
thank you. All right, thank you. Next, we'll move on to our speaker. Tadra is going to introduce our speaker for us. Take it away, Tadra.
Hi, yes. So during this session, Chevelle Mavens, one of our own, will be giving a presentation about mental illness and addiction among older people. Chevelle is the founder of Addiction Prevention LLC, where she provides training on substance use, mental health, and wellness. Also, she is a social worker with adult services within DSS, where she investigates cases of abuse, neglect, and exploitation of older adults. So thank you in helping us welcome Ms. Mavens for her presentation on addiction and mental illness among the elderly.
Hello, everyone. Now let me see if I can share a presentation with you. Can everyone see that?
Yes.
Okay. This out the way. I'm not used to WebEx. Thank you, Tadra, for introducing me. Yes, I am a social worker at Chatham County Department of Social Services. We wear various hats there. So I hope this information that I present to you today will be beneficial for the individuals you work with or even your loved ones. So what I'd like to start out is talking about the learning objectives, what you will get from this presentation today. We're going to talk about why aging in America is important, understanding mental health in older adults, substance use disorder awareness in older adults, and what can we do to help. You know, the reason that we're having this presentation today is because the current population age 65 and older is one of the most significant demographic trends in the United States. The baby boomer population, which peaked in 1999 with 78.8 million baby boomers, that included immigrants that also moved to the United States. And we're looking at they were born between 1946 and 1964. So let's see how this affects us currently. Every day, 10,000 people turn age 65. By 2030, which is not far away, baby boomers will be at least 65 years of age. Here in North Carolina, by 2025, 1 in 5 North Carolinians will be 65 and over. And I think this is interesting, which is going to affect a lot of DSS, is by 2025, 89 counties in North Carolina is expected to have more people age 16 older than 18 than younger. This U.S. population is growing because we are living longer, and due to the part of, you know, our better health care, the technology that we have, we're living longer, which is a good thing. But with that, it can come other issues. Here we go. So let's look at the impact of mental health in our older adults. It's here. Mental health and substance use and aging is a double stigma. Because of the stigma that is connected to mental health and substance use, a lot of time we see that they're not respected. And what we also see is sometimes people that are older, they're not getting the same type of respect. They have this stigma. And sometimes we use terminologies, you know, with substance users, mental health and aging, that it doesn't show respect for them. When mental health is not addressed in the older adults, it can be mistaken for a physical health problem and not receive the appropriate medical care, which can be a problem because you're not treating the correct issue. So later on, I will discuss in the presentation some physical symptoms that can be associated with mental health and substance use that might mimic other health conditions that people are experiencing. Many people, including medical professionals, believe that mental health is a part of aging process, which is not true. And I want to drive this into everyone. Because someone is older does not mean they should suffer from mental illness or substance use disorders. Their emotional feelings and emotional well-beings are sometimes disregarded. We all age differently. We all go through the aging process differently. Because we age doesn't mean that mental health condition is a part of that aging process. When working with our older adults or our older loved ones, we have to consider late life transition and what that actually means. How the late life transition, how mental health and substance use can develop in these later years. And a lot of times we don't look at that transition. So let's look at here, late life transition. So again, every stage in our life, we go through a transition. Think about your life. Think about the transitions you've went through. For example, leaving home for the first time, going to college or moving out on your own, that's a transition. Getting married, that's a transition. Having children, if anyone have children, you know that's definitely a transition. Every milestone in life is a transition, regardless whether the change is expected or not. The way people cope with change vary by person to person. We all deal with it differently. So here's a little activity I would like to do with everyone. I would like for you to close your eyes and ask yourself these questions and think about how you would cope with it. Imagine being on a fixed income and finding it difficult to make ends meet. Imagine how you might react to being lonely or isolated in your home. Imagine taking on the role of a caregiver for a spouse or significant other, seeing that their health is declining and later dealing with their death. How would you cope? I definitely don't know how I would cope. We do know that some common life transitions that we all will have one day, like retirement, relocating, bereavement. But health conditions that sometimes arise in late life can also affect other areas in our life. So as we age, our health decline. A lot of the clients that we work with at DSS, we see them diagnosed with things like COPD, diabetes, memory issues, taking multiple medications. With increase in life events like changes in your finances, threat to your independence, and onset or reoccurring depression or anxiety or other mental health disorders, some individual might turn to substance use to cope, just to get rid of that feeling. Let's look at the most common mental health disorder among older adults. So we're going to look at anxiety and depression. So anxiety and depression, 1 in 4 adults have symptoms of mental illness in any given year. That's 1 in 4 adults. Depression and anxiety is the most common mental illness in older adults. Anxiety and depression, they have similar signs and symptoms like fatigue, lack of energy, constipation, mood swings, irritability, avoidance. And we also see with anxiety and depression, frequently they co-occur. And co-occur means they usually happen at the same time. Usually someone that's experiencing anxiety also has some depression, and some people experiencing depression also have some anxiety. So when I'm talking about anxiety and depression, I'm talking about a diagnosable disorder. Of course, we all have our highs and lows. That's a part of life. As I mentioned earlier, many people believe feelings such as sadness or depression, anxiety, and depression are part of the natural aging process, but it's not. If we see a person's ability is hindered, if we see a person having a hard time carrying out daily activities, problems with working or volunteering as they once did, and or problems maintaining or satisfying, maintaining satisfied relationships with their friends or their families, we have to consider a mental health disorder could be developing. When we see a person thinking pattern, emotional state, their behavior change, we have to think about there could be some mental health going on. So again, I'm not talking about, the anxiety you get when you're late for work. I'm not talking about the depression you might feel when it's constantly raining. I'm talking about a diagnosable anxiety depression when it start affecting people thinking pattern, emotional behavior, their state of mind. We have to consider it could be a mental health. And if we identify these signs early, these behavioral changes, we can address it early on. Because we know anytime you take long to address something, it's going to be harder to address later on and down the line. So let's look at some of the signs and symptoms of depression. I broke it down to 3 different things here: the psychological, physical, and behavioral. And I'll put them all up here. So when someone is experiencing depression, they won't have all of these symptoms. So we know that you might have some anxiety. Like I said, anxiety and depression can co-occur. Guilt, anger, mood swings is a big one. Being a pessimist, some memory issues, concentration. Remember, depression, if you're not sleeping properly, it affects your concentration. Fatigue, lack of energy, sleeping too much. Here's some behavioral: crying spells, withdrawal, neglecting responsibilities, or lack of interest in your appearance. So if you're a person that, you have someone that always took care of their responsibilities, always, had their hair together, their clothing, and you start to see these things are neglected, that could be a sign that something else is going on, and we should try to, figure out what's going on with that person. So looking at these symptoms, you can see how a primary care doctor would prescribe a medication for a physical symptom, and not maybe ask the questions about the psychological behavior. So if you're not sleeping, they might give you a sleep aid. If you're having, fatigue, they might prescribe a medication for that. A lot of times they don't ask that psychological part, those questions. I think doctors are doing better, but we still have a long way to go. Again, prolonged depression over time can be a risk factor in itself. One of the things that I'm not spending a lot of time on today, but I do want to mention that one of the risk factors is suicide. When looking at suicide as a risk factor for older adults, we have to consider if you have that person that have the feeling of being hopeless, having chronic pain issue, limiting function, isolation, having a hard time adapting to change. When a person is experiencing that, we need to, and when it's not addressed, it can lead to suicide. And one of the things that many of us don't realize with depression, it's a chemical in our brain. It affects the brain chemicals, neurotransmitters. When I describe neurotransmitters, I like to look at it as a highway, an information highway in your brain. The neurotransmitters are like vehicles, and they send messages to the nerve cells. So when you're depressed, there's a reduction in their neurotransmitter. So you don't have as many cars driving around on the information highway in your brain. That's what a person is when you have that lack of neurotransmitters in the brain, those cars on the highways, they're feeling depression. That's the outcome of that. Suicide is a public health issue for older adults. And here's some statistics. 1 in 4 older adults who attempt suicide will die, when compared to 1 in 200 youth. So every 1 to 4 older adults who attempt suicide will die, when compared to 1 in 200 youth. That's staggering to me. We do know that 51% of all completed suicides are with firearms. With older adults, that number rises to 70%. To me, those are staggering. So let's go to anxiety. Let's look at here with anxiety. As you can see, look at the physical symptoms here. If you have someone that's experiencing pounding of the heart, chest pains, rapid heart rate, blushing, fast breathing, maybe some dizziness, numbness, tingling, we're going to look at that usually and think, is this person having a heart attack? Because those physical symptoms do look like a heart attack. They look alike. So, what I always suggest to people, and I talk about this in my mental health first aid for older adults, is when you're with someone that might be 55 or older and they are having these symptoms here that you see in the physical part, you should err on the side of caution and call 911 because it could be a heart attack just because of the age. But I think it's also important if you're with someone, ask them if they ever felt this way before, because they might tell you, yes, I have anxiety. But if you're unaware of that, I would want you to call 911 because we know that with heart attacks, they need medical attention right away, not to play around with that. But again, you look at the symptoms of anxiety and a heart attack, they look similar. And in a person, self-disclosure, I have anxiety. In my mid-20s, I had these symptoms and I thought I was having a heart attack and I went to the ER. Thank God it wasn't a heart attack, but that was anxiety. That was my first experience. And I'm like, wow. So, I think it's important to know these signs and symptoms, but when we're looking at age-wise, they consider the elderly starting at age 55. I don't agree with that, but they do consider age 55 and up to be older adults. We have to consider that this is a possibility. It could be a heart attack. And again, like I said, in my mental health first aid training, we actually role played this and dive deeper into anxiety. I also have another training, baby boomer co-occurring disorders, where we take a holistic care component, which includes the body, mind, and spirit, like treating the whole person. We look at the whole person and seeing all the areas we can help a person to overcome any type of issues in their life, or at least put those tools in their toolbox. So let's move on to more with anxiety here. So occasionally anxiety is a part of life. Again, being late for work, being on traffic on 440. God, I've had that experience. But anxiety disorder involve more than a temporary worry or fear. Again, when I'm talking about anxiety, this is something that can last longer than 6 months, and it interferes with the daily activities and consider anxiety disorder. But again, we need a professional to diagnose someone. But if you have this information, you notice that either yourself or someone you love or someone you're working with had these symptoms and it's been longer than 6 months and you're seeing it also is interfering with their daily activities, we have to consider there's a diagnosable disorder here. But that's when we let the professionals go in and do what they do. Anxiety, like I said in the beginning, is a common illness among older adults. It affects around 10 to 20% of the population. However, I believe it's much higher because it's not identified. And again, you get this 10 to 20% of the population because these are individuals that's actually going to medical professionals and getting diagnosed. So that means a person know what they're feeling, they're going to the doctor, and the doctor's diagnosing them. That's where we get this 10 to 20% of the population. But we do know it's much higher because a lot of people have this, and because of different reasons, they don't get help for it. So we're seeing an increase in mental health and substance use among older adults because sometimes they self-medicate. One of the things I want to mention before I leave this here is this slide at the bottom. Among adults, anxiety is the most common mental health problem for women and the second most common for men after substance abuse. I thought that was interesting, but we're going to talk more about the substance abuse. Here, substance use and prescription medications. So one of the things I would like to stress is you will hear the word drug addiction, but it's also called substance use disorder. This is a disease that affects the person's brain in their behavior and lead to inability to control the use of illegal, let me start that over. It's a disease and it affects a person's brain. It affects their behavior. They have the inability to control once the illegal or illicit or medication. So this is for prescription medication, legal drugs, for example, alcohol is a substance, and this is for prescription medications. Here, I want to show is that this is the brain. So on your right-hand side, you will see the this is a part of your brain. This is what a healthy brain looks like. A person that doesn't have a substance use disorder. On the other side, you will see a substance use disorder's brain. And you can see that it looks very different. You see that with the substance use disorder, the yellow part, it almost looked like a fluorescent green. It's not much activity going on. And the dark spots you see is actual holes in the brain. So we see how a healthy brain looks versus a substance use disorder brain. So every drug affects the brain differently. However, we know that it affects the brain communication system. So again, if you had a brain of someone that used cocaine or methamphetamine, it would look very different than this brain here on the left, because every brain affects every drug affects a part of the brain differently. Here, I think is important to mention that the chemicals in the brain actually works with the communication in your brain. So when you add a substance in your brain or into your body, it communicates with your brain, and it interferes with the way that the nerve cells, normally would, receiving and processing information. So for example, if you have a headache and you take ibuprofen, in a couple of maybe 20 minutes, the headache goes away. That's because you took the medication, it communicated with your brain and interfered with the pain sensory in your brain, and they process it. Okay, I must stop this pain. We no longer feel it. That's the same. That's what all drugs affects the brain. Different drugs, because of the chemical structure, work differently in every brain, and it'll affect different parts of the brain. I think why I wanted to stress this is that a substance use disorder is a medical problem. A lot of times we don't want to look at substance use as a medical issue. We have that stigma, and we need to start treating it as a medical problem, which would help eliminate the stigma so more people can get help. Substance use disorder is a medical issue, just like someone suffers from diabetes or high blood pressure. So let's look at, here we go. Substance use and prescription medications. This is important. Over the next 2 decades, the number of older adults with mental health and or substance use disorders will double from 8 million people to about 14 million people. That number is staggering to me. Let's look at the bullets that we have here in the slide. Older adults with substance use disorders expected to rise from 2.8 million in 2002 to 2006 to 5.7 million by the end of last year. And I bet that number is higher because when these stats was predicted, we did not have COVID. And we know that COVID, one of the things they said that alcohol was one of the things that was constantly purchased, also was one of the stores that was never closed during the pandemic. So that number would not surprise me if it increased. According to the National Survey on Drug Use and Health, illicit drug use is more prevalent among American older adults than any other older adults in any other country. So basically, we have more drug use in America by older adults when compared to any other country in the world. I think that's staggering. And it could be we have more resources. It could be that we have the money to buy it. It could be of various reasons. But alcohol, prescription drugs, that's from your doctor, for age 60 and up is the fastest growing health problem in the US. And I think we can see that when we're looking at television, all of these commercials come on. I mean, if your little toe hurt, you can get a medication for it. People age 65 and older make up 12% of the US population, but account for 30% of all prescription medication use and 30% over-the-counter medication. So 12% of the population, older adults, 65 and older, but they account for 30% of all prescription medication and 30% of over-the-counter medication. Now, why is this information is important because there's a negative consequence of improper use of these drugs over with alcohol, illicit drugs, that's illegal drugs, prescription medication, and over-the-counter medication. And why? Because it intensifies in an older body. And what I mean is that we can see physical changes of aging on the outside. We can see it through your skin. We can see it through your hair. But a lot of times we don't think of or even consider the significant internal changes that also come along with age. So if you have a liver, your liver when you are 1 year old do not work the same way as it does when it's 60 years old or 70 years old. And when we add these drugs on top of it, it causes more issues and other health issues that can come along with it. For example, drinking alcohol on a regular basis can cause the liver to break down. So if the liver breaks down, that's going to prevent medication from breaking down in your body the way it's supposed to break down. Also, it can cause toxins in your body that won't break down. So now we have other health issues. So let's look at the impact and high consequences of substance use prescription drugs. So between 2001 and 2020, that's the end of last year, it was estimated, increase of 100% of medication misuse among older adults. According to researchers, about 60% of older adults take their prescription drug improperly, and approximately 140,000 die each year as a result. Now, that approximately 140,000 die each year as a result, I think is much higher. I think there's not autopsies done with all people they find in their home, older people in their home, they don't do autopsies. A lot of times, we knew they were going to die, but that doesn't mean that we should not find out why they did pass away. So that, to me, I think that number is much higher. Older adults are often more susceptible to effects of drug because of the body age, like I just talked about, for example, with the liver. It can not absorb and break down drugs and alcohol as it once did. When we age, we have to consider that all of our organs also age. And a part of the aging process, if you add substance use on top of that, that's going to even exacerbate the use of our organs. Provider may be confused symptoms of substance use with other symptoms of aging, which can cause, include chronic health issues. So again, that's that conversation that the doctor has to have with their patients. I think also as a role as a social worker, it's my job to have these conversations and look, deep dive of what my clients say they're experiencing as far as their physical sense, and also be observant what's going on, what we see in their homes. So when we combine depression, anxiety, substance use disorders, we have other health risk factors. And here's one of them, perceived poor health. Again, like I said, depression it feels heavy, sometimes it's painful. It can look like a cognitive disorder, anxiety. It can cause constipation. It can feel like fatigue. You constantly have these issues and you're going into the doctor, there is going to be perceived as poor health when it could be depression, anxiety, or substance use disorder. Progressive disabling sensory loss. So, mixing over-the-counter medications, mixing it with alcohol, mixing it with your prescription drugs, it can cause issues with your sight. It can cause issue with your hearing. So it can cause some muscle weakness. So it can be disabling. History of recurrent falls. We at DSS see this all the time, the history of falls. And it could be falls because the person is losing some mobility with their muscles, but it also can be, again, with the depression, feeling heavy, with anxiety, moving around so quickly, not paying attention. It could be substance use, staggering around. It could be over-the-counter medication they're mixing with other substances. For example, Benadryl can make you very sleepy. And if you're already on a pain medication, you add those together, it may not be a good outcome. And we do know from statistics that the more a person has an admission to a hospital and rehab, the quicker they decline in their life. So when we see that all the time in at DSS, and we always try to come up with a plan when we start to see these readmissions in the hospital for our clients. As I talk about the cognitive impairment and dementia, you can experience that with anxiety, depression, and dissatisfaction with social network, that isolation, not wanting to be around people. This could be one of the risk factors for someone that is suffering from anxiety or mental illness. I'll just say mental illness and substance use. These factors can be invisible if we don't take a look at for what it is. And I say that because let's start with the first one here. Older adults with alcohol problem increase, but the problem is unrecognized and untreated. So again, if we're working with someone, if this is a loved one, if we're spending time with them, be observant, but also on the flip side, for me working in a hospital as a substance abuse therapist, many substance abusers are great maskers. And when I say that, they can mask their addiction. So I think it's important for us to be observant, to ask questions, but also know that it might take some time to really find out what's going on with a person that's suffering from a substance use disorder, because they're good at protecting that drug or alcohol. That's why it's called the addicted personality. They learn techniques to protect that. And when that happens, they're not treated. They're not getting the treatment that they need. And also we have to look at the lack of training, hurried doctor visits. Medical providers often overlook alcohol problem among older adults, and illicit drugs. A lack of training. I think is important for, if you're in the helping field, to get substance abuse training, to get mental health training. You are not going to be working in this field or just being around people and not be affected by substance abuse or mental health. It is so prevalent that someone you love, someone you work with, either that's a coworker or even if that is a client that you have, is going to experience this. And I think it's important for doctors and nurses, and they're doing a better job. I do want to give them credit. But if it's not looked at, it's going to be overlooked. They're not going to be treated. Our older people are not going to be treated properly. Again, medications, symptoms can mimic other disorders that is linked with older adults. So that's getting to know the person you're working with, knowing what medication they are. When I do my assessments, I always ask to see their medications. A lot of times they just want to tell me their medications. I ask them, can I see them? I ask if they're taking any over-the-counter medications. I write that stuff down because when something occur, I can always go back to my list that I keep in my assessments and did you ever consider this could be affecting you? Have you talked to your doctor about it? Older adults often don't ask for help. And this is because, go back to the stigma, being ashamed, privacy, just being a private person, and their adult children is ashamed that their parent have a substance use disorder. So again, the more we talk about mental health, the more we talk about substance use disorder, the more we look at these as a medical issue, it will stop the stigma. It would eliminate the stigma, and people won't be ashamed for saying what they're feeling, what they're doing, and they can get help. And again, we talk about it more. Adult children will be more apt to get help for their family members. So what can we do to help? So let me put all of them here. What we can do, let the person know your concern. Talk with them with respect. So let the person know that you have some concerns. If you observe something, talk with them. I have done that with my clients. Sometimes they don't like me asking them questions, but I always let them know that I'm doing it because I care, and I just want them to have the best life possible. So just talking with people with respect and just generally, that you care. Tell the person what you observe. For example, you can say, hey, I noticed when I take your trash out each week, you have several wine bottles. Or, hey, I've noticed you've been sleeping a lot. How do you feel? So, not only talking with people, tell them why you're talking to them, your observation. I think the next question is, and we practice this a lot in mental health first aid, is ask question without dread. For example, don't say this. I know you don't have a drinking problem, do you? Well, you just answered the question for yourself, and then you kind of gave them the answer. If you don't feel comfortable, which is fine, some of us don't feel comfortable. That's okay. The next one is actually get someone that can help you. We are so fortunate having UNC, Duke, Wake Med, doctors, nurses, social workers that have this experience. They can help you with this if you're not comfortable. And I think the next one is appear confident, and be reassuring. So in my mental health first aid training, we practice this because it's important. If you appear scared, that can sometimes cause issues in the conversation. If you appear that you have all the answers, that doesn't work either. And I always stress to people, because someone is experiencing mental health or have a substance use disorder doesn't mean they can't read the room. It does not mean they can't read bull crap. And it doesn't mean they won't call you on your bull crap. So, be honest. If you say, this is what I see, I'm not sure what I can do about it, but I would love to help you. Honesty is the best policy, just being honest with the person. And again, I practice this in mental health first aid because it's helping someone. You want to be confident in your ability. And sometimes role playing do help. And the last one here I think is important is to get assistance from a professional that have the clinical experience, that has a degree in the area, to assist you, to provide you the care that person needs and support you. Because this is, when I look at substance abuse and mental health, it's not just that individual problem, it can be a family problem. And it can be traumatic for the entire family. And everyone needs support, not just that individual. They all need support. So that's why I feel it's very important for you to reach out to addiction specialists, reach out to your primary care physician. A lot of times they have social workers in the doctor's office, the addiction mental health counselors, a geriatric social worker. I love geriatric doctors. Just like we take our children to pediatric doctors, I think for older people, they should go to a geriatric doctor, and they specialize in the aging body. So a lot of things they may have information on, the latest research. They may be able to identify things much quicker than a regular primary care doctor may not have that knowledge. Doesn't mean they can't learn that knowledge, but a geriatric doctor actually, their whole perspective is just on the aging body. And with that, I'm done. Here's some information. If you have any questions about anything that I've said today, or have some questions that come up later, you can email me. You can follow me on social media. Addiction Prevent on Instagram. If you have a phone, if you zap that UR code, you will get me. You'll be able to see all the stuff that I'm doing in different trainings that I do throughout the year. And with that, I'm done.
If any of you have questions for Chevelle, you can enter them in the chat box and she'll be happy to answer them for you.
Did I stop sharing, by the way?
Yes,
No?
you did.
Oh,
No?
yes, you did.
Okay, I did. Okay. So let me see the chat box. Could you see? Someone asked, could you share your presentation on the screen? Could you not see my PowerPoint?
Yes, we could.
We saw it.
Okay. Okay.
It's also
Like,
available on our website.
Yes.
Okay, I don't see any questions coming in, Chevelle.
Okay.
But if you'll stick
Actually,
with
I
us.
had a question.
Okay,
Yes.
great.
I put it in the chat. I guess I don't know if it got to everybody or not, but I was just curious, Chevelle. As you were talking about it, I was thinking about, when you gave this statistic at the beginning that by 2035, everybody's going to be 65. So I calculated my age. Yes, I fit in that group. I'm going to be one of those demographics. But it also started me thinking that this generation, the Boomer generation, is also the Woodstock generation. The one that sort of, as I said in the chat, that lived the credo: tune in, turn on, drop out. Certainly not everybody in this generation, participated in various lifestyle choices as earlier young adults. But I'm just curious to know whether or not there have been any studies of this generation to kind of see if there are any correlations between the earlier lifestyle, choices, drugs, alcohol, whatever, and the prevalence of substance abuse, alcohol abuse, mental health issues. I'm just curious to know if you're aware of any such studies.
Yes, John. Thank you. That's a great question. Actually, what the statistics tell us with any age group, if you're using at a younger age, and I can tell you, if we go on any college campus, we can get a diagnosis. And I'm not going to say I was one of them at one time, but you can get any diagnosis. But when you leave, a lot of times what we do see is that when they become older, and when I say older, graduate college, get that job, marry, they take on that responsibility role. And for half of that population that was using, and that could be substance with alcohol, illicit drugs, they stop and they go in and become parents. They're responsible. Maybe they drink responsibly, but then we see it pick up when they retire. And when they retire, it picks up because, again, you don't have that responsibility anymore. Your kids are grown, they're married, they're out the house. You've already worked your 30 years in your field. But when they do pick up, they pick up where they left off, which is the dangerous part, because they start, you haven't used in, let's say, 30 years, and you pick up and say, I used to be able to drink a 40 ounce, I can do this. They actually grow into their addiction way quicker than a person that might start their addiction in their 30s or 40s. We do know that. Now, as far as the Woodstock individuals that lived during that time period and participated, I have not seen a study from those individuals that say that they're the ones that with this high number of substance use. I haven't seen that yet, but I do know that a lot of times, if you did have a substance use behavior when you were maybe in your college years, you have a higher probability of regaining that again once you retire. So that could be where those numbers are coming from. And again, I think one of the things we do see with substance use, especially alcohol, is growing, is one of the growing addictions for everyone in the United States. Not everyone in the United States when we look at substances, but actually older people, because it's available. You can go into Walmart. No one is going to question you buying a 6-pack of beer. And we see that. And what we also start to see growing is marijuana use. That actually has grown 200%. But that's a whole nother training that I would have to get into, also with the CBD and the THC. But that would be another hour to talk about.
Yeah, I was just wondering if maybe there were some negative effects on the brain that again,
Well, with the brain, actually, anytime you anytime you use a substance, it affects the brain. Sometimes your brain is able to restore, but it would never be how it was pre-using substances. So the brain is always altered. But when it's heavy use over a long period of time, it's going to sometimes it take longer if the brain recovers at all.
Right. Okay, I'm just curious. Thank you. Great
No
presentation.
problem. Thank
I
you.
see another question, this one from Pam. She says, do you find a lot of substance abuse is hereditary, Chevelle?
So here's the thing about hereditary. Because your parents had a substance abuse issue doesn't mean that you would automatically have a substance use disorder. It just means that you have a higher probability of actually having a substance abuse disorder. So I always, when in treatment, I would have people say, well, my mom or my dad was a drug user, because so I already knew that was going to be for my life. Not necessarily. It doesn't mean that, but it does mean that you have a higher probability of actually having substance abuse issues, but it doesn't mean that you will have one.
Okay, we have a question from Leo Bolin. In your experience, is the opioid addiction more prevalent than alcoholism? Why has the recent focus for attention and treatment been for opioids versus alcoholism? Any thoughts?
Yes. Actually, what is being used more than opiate is actually cocaine. Crack cocaine has come back. It has been that way for a few years. Honestly, the opiate addiction has gotten so much money because what opiate addiction affected. And it goes back to systematic racism. That a lot of people that were affected with the opioid is suburban white families. And because when we look at the numbers of people that was affected by opiates and consider back in the 70s and 80s with the crack addiction, that should have also been an epidemic that we should have thrown money at. And really, it's just about the population that was affected with the opiate addiction. What we're seeing is really is cocaine is the focus. I should say, excuse me, let me rephrase that. Cocaine is the more use of cocaine than opiate right now, but we're just seeing a lot of funding from the government thrown with the opiate addiction. And it's unfortunate because it should just be thrown at substance use. And again, if we look at it as a medical issue, we will put the money in to help people because it's the same treatment that a person would get if it's alcohol, if it's opiate, if it's cocaine, if it's marijuana, meth, it's the same. But, that's my spiel on opiate versus alcoholism.
All right, Pam has a
Is it
question.
because
Is it because doctors are prescribing opioids but not crack cocaine?
Well, I hope doctors are not prescribing that because it's not legal.
Yeah.
But I mean, it's not, honestly, it's not easy for everyone to get prescription for opiates, as you might think. I worked for a hospital for almost 15 years. And, I can tell you that it really is based on the doctor. I also think it's really based on the state you live in, on the prescriptions that was giving out. I know there was a lot of safety measures put in place, but again, you have doctors. I've worked with some doctors that actually was selling prescriptions in New York, and working with the state, they actually was able to crack down on that. I think that they're doing a better job now managing the prescriptions they're taking out. I can tell you, my son recently had a tooth pulled, and he could not get any prescription to help him for that. So they're doing a better job. But I just think that, again, it was with the population that it was affecting the opiate, that so much funding was pushed to help individuals. When we look at the same individuals that with other drugs, that funding wasn't pushed. And it was just a different face. It's a harsh reality, but that's the reality. Is there an issue with pharmaceutical companies or pushing them? The pharmaceutical pushes everything. They're the driving force of all medications. And also with the opiate, you can see, for example, Johnson & Johnson, the lawsuit that they settled. They knew a lot of the information of how addicting the medication the opiate medication they were making, and they did not disclose that. So I think the responsibility have to go all the way around. And I'm actually was very pleased that there was a lawsuit with Johnson & Johnson, and that, some people will get some type of compensation, but again, that's life. There's so many children out there that their parents were incarcerated, or their parents actually died from overdose of opiates, and that money is not going to compensate and bring their parents back.
It's a question from Althea Jones.
Yes, it says, we as baby boomers are social beings. COVID has negatively influenced socialization, thereby causing many of us to depend on painkillers and other substances to gain a feeling of acceptance, being needed, etc. Please share some information regarding strategies to use to positively impact social engagement. Senior centers are working at less capacity, etc.
Yes, and I think with that, one of the things I think we're missing in our society is neighbors. I think it's important to check on our neighbors. And it's unfortunate being with COVID. We are isolated in our homes. We're not able to be as social as we once was, but it doesn't take much to call somebody. It doesn't take much to, either write someone a letter. It doesn't take much to talk to them from a social distance on their porch. I help my neighbor next door, and I don't go to her front door, but I can talk to her across the lawn. So I think that's some of the things that we have to look at, what roles we can take when we're dealing with our older population. What can we do? We can't just focus all on the senior centers, because yes, again, they're at less capacity, and we do understand why we want to keep our seniors safe. But what can we do? What roles can we play for our neighbors, for our church members? There's a lot of things that we can do for our church members. And we know if they're your church members and involved in the church, if they have anyone living with them, that they might have, their spouse might be deceased. It doesn't take much to cook dinner, put it in a container, ring the doorbell and said, I just left that out for you. That means a lot to a person. So it's about quality, not always quantity.
Connie Moore says they're closed again due to rising COVID numbers, I'm guessing, but we call our participants and their caregivers every day to check on them and just chat. It makes a huge difference.
Mm-hmm. I
Just
would
what
say
you said, Chevelle, contact.
Yes, and I must say our Chatham County senior sitter, and maybe, I think they're the best senior sitter. They're doing an excellent job. When I talk to my clients, my clients have figured out how to play bingo on their phones with the senior center. So one of my clients, every Monday right now, she's playing bingo every Monday and Wednesday. So they have done an excellent job of teaching our seniors how to use technology, mailing them still schedules, get them on a schedule. So they're doing an excellent job. So I'm glad to hear that. And again, like I said, it's about quality, not quantity.
All right. Any more questions for Chevelle? Chevelle, thank you for a great presentation, and thank you for being with us today.
Thank you.
All right, so next is Nancy Warren, our advocacy chair. Nancy, any updates for us?
Okay. Yes, I actually have lots of updates for us. So,
Okay.
yep. So I want to talk about several items, particularly. Let me just get my notes here. We have 3 items that I want to get people up to speed about and remind them about. One is the American Rescue Plan Act and the authorization of funding to all 50 states and all the territories, specifically for adult protective services. So you'll recall that last spring, with the COVID Relief Act, or however it was phrased, there was funding to states, to all states and territories for specifically for adult protective services. So then later this spring and over the summer, the American Rescue Plan Act has authorized money to all states and territories again for the provision of adult protective services. And that actually has two funding cycles. That'll be this fiscal year 21-22 and then 22-23. So for the next few years, there will be a significant increase in federal dollars for states to use for the provision of adult protective services. In states like North Carolina and other states that are considered to be, and if there's anybody on from the Division of Aging and Adult Services, and they can, clarify anything I say, I'd be glad to hear from them. But in states where it is a state supervised, locally administered, like it is the APS program is in North Carolina, a lot of those dollars do go to the state that allocates those dollars to the local providers to enable them to do all kinds of new and interesting and creative adult protective services. So that's one pot of money that's been coming. The the Build Back Better Act, which is another piece of legislation which is going through the markup right now. It's been through House Ways and Means. It will. This is interesting. It's going to expand Medicare coverage to. It proposes. Yes, we do, Connie. We do know how much North Carolina got in the first round of the American Rescue Plan Act. North Carolina received about $2.5 million. So, it's allocated using from the administration for community living based on the Older Americans Act funding. I think that's correct. So that formula. The Build Back Better Act, which is being marked up by the House Ways and Means and may have finished it. I was saying it proposes to expand Medicare coverage. This is important to a lot of us, and to include dental, vision, and hearing benefits. So we'll see how that goes. It's also, it proposes to fund elder justice programs that increase support for state and local adult protective services offices and long-term care ombudsman programs to better prevent abuse, neglect, and exploitation, and a lot of other staffing shortages and such. And then the third item I want to just mention to you all is the Elder Justice Reauthorization and Modernization Act of 2021, which proposes increased funding for states to support APS at the state and local levels for each year through federal fiscal year 2025. In addition to authorizing $400 million per year for states for APS, the bill also calls for $75 million for APS demonstration projects to support and improve APS services, including the National Adult Maltreatment Reporting System. Specifically with regard to the Elder Justice Act Reauthorization and Modernization Act, we see that there's, let me just see here, I'm trying to find my language, $1.4 billion for APS functions and grant programs, $250 million to address social isolation and loneliness. Now, this is really important. It even connects with a little bit with what Chevelle was talking about this morning, and it's been something that's been on my mind for a lot, even in terms of conference ideas, this whole issue of social isolation and loneliness and the consequences. When Chevelle said, when you make dinner, pack up an extra and share it with your neighbor as a way to combat that. And it also, let me just see, they're also proposing money in that, in the Elder Justice Reauthorization and Modernization Act for money to beef up, if you will, multidisciplinary teams, to include to integrate the expertise of lawyers into health and social services settings to help clinicians, case managers, and social workers address structural problems at the root of so many health inequities impacting older adults. So at any rate, there is a lot going on. There is a lot of new money. The money that was awarded from the American Rescue Plan, I shared that with the partnership folks. It says they allocated $85.4 million in American Rescue Plan funding for states for adult protective services. So, and I will just say, I looked at the state budget. The governor originally had in his budget funding state dollars for funding for adult protective services. When I look at, and again, if anybody knows differently about this, but I was taking information from the Coalition on Aging, Heather Burkhart and I had a couple conversations, but I don't see any funding in either the House or the Senate version for state dollars for adult protective services. There's money there that authorizes the expenditure of the federal allocation of what we call the ARPA, or the rescue plan money. But so anyway, that's pretty disappointing. But otherwise, there's a lot of federal dollars coming, and that is the best news for adult protective services in like 150 years. And we're all just scrambling. And I will say to the group, all of you all, that I work part-time now for the Adult Protective Services Technical Assistance Resource Center, which is the agency that contracts with the Administration for Community Living. And our job, my job and others that are my colleagues, is to work with states on their spending plans and their long-range planning for improving states' adult protective services programs. This is very exciting. It's very different than the hole that we have been in forever, bemoaning the fact that we have no dollars for adult protective services. So it's a pretty exciting time. And I don't know, maybe there's somebody on the call from, maybe there's someone on the call from Aging and Adult Services who'd like to say something specifically about that. But at any rate, that's my report to the group. We had nothing to do with all of that good news, except that I will say that the National Adult Protective Services Association and the colleagues there, of which the partnership is actively participates in NAPSA activities, has been advocating, of course, for this for as long as I've been in adult protective services, and that's a god awful long time. So at any rate, this is all good news, and we're glad about it. And there you go.
Well, before Nancy stops, I want to jump in and just say that she forgot to mention that she was responsible for coordinating the compilation or publication of this incredible. Look how thick it is. It's 100 and how many pages? I don't know, a lot. But it's the first ever, people, the first ever in the nation comprehensive handbook for district's attorney on prosecuting all forms of adult abuse and exploitation. And Nancy and the Conference of District Attorneys needs to be congratulated for all the hard work in pulling this thing together. It's just an incredible resource. And I want to encourage those of you with senior adult protective services to now reach out to your local district attorney and say, hey, I know you got one of these things. Let's start talking about prosecuting some of these offenders, okay? And, reacquaint yourselves or reacquaint them with you and the work that you all do. And let's get some of these people behind bars.
Absolutely.
So thank you, Nancy.
Thank you, John.
Yeah, thank you. Thank you, Nancy,
you were
for all
real
your
true,
hard work
too.
always. All right. Awareness. John Marin and Stephanie Bias, co-chairs. John, you got the video?
I got the video. I got the conch. I got the conch. Let's see who recognizes that reference. Anyway, I'm going to sort of defer to Stephanie. She's been out on the road a lot more than I have, but me and Ann Elmore from Secretary of State's office, we have been doing events, not nearly in the quantity that Stephanie has, but and most of ours are still being done via webinar. A lot of the agencies and the entities that we are doing things with still prefer that method. So we're still doing that. We have a number of things scheduled ongoing, but I'll let Stephanie talk a little bit about some of the other activities that we've been doing extracurricularly, I guess.
Thanks, John. Yes, we have been out on the road. In fact, Kevin is on the road right now doing Retired Government Employee Association meetings. My colleague Jeannie Skepsey will be going and in a few weeks and doing that, and Kevin will do some more, and I do some next week. So our numbers are not as big for those Retired Government Employee Association meetings as we have had in the past, but they have been. I think sometimes it's not your strength is not always in your numbers. It's the quality of the questions that they have and the material information that we are able to get out to them. So we're very thankful to continue to be a part of that partnership, and we haven't been together since really fall of 2019 doing that. So that we've had almost 2 years that it's been a while. I've been out on the road doing presentations. We've done a few things virtually. We have some outreach events that we have coming up that I'll be in Moore County tomorrow, Laura, at the Senior Enrichment Center. Yes, I will. My colleague Barbara Pope and I will be there representing SHIP and S&P. And we always, of course, talk about the partnership. And being a part of the partnership is also important to us, but it's also important to John and myself as we are the co-chairs for the North Carolina Senior Consumer Fraud Task Force. And tomorrow, Friday morning, what day is it? Tomorrow, Friday morning, I will be recording a message on utility scams for the North Carolina Senior Consumer Fraud Task Force. John has done one for the North Carolina Senior Consumer Fraud Task Force, and Kevin has also done one for the North Carolina Partnership to Prevent Adult Abuse. So NCP3A and Consumer Fraud Task Force, we've gotten a lot of good plugs. So they are done with Steve Hahn for AARP, and he's always looking for voices to speak that, that can, they write the script, they tell you what they want you to do, and then we're fine. And that is something that we're always important about. Yeah. John.
Yeah, this is AARP has what they call the Fraud Watch Minute, and
Fraud Fighters. Yeah.
You can find them on their YouTube channel, AARP North Carolina, or through, I guess, their Facebook has links as well. So yeah, I mean, those are great.
I've got the script all printed. I printed ahead and printed it out, bolded what I wanted to accentuate. Hey, listen, I wish I could just memorize it, but the utility scam is really, it's something that is, it is no respecter of persons. People say, we've overpaid, we're going to give you your money back, and da-da-da-da-da, and that's not true. Or they say you're going to cut your power off, and, we haven't got your money when you've paid them. And, I mean, it's a fear tactic. And people, of all the things people don't want to do without, it's their utilities, their power and the water or whatever. So I think I'm appreciative that we have this opportunity to be able to talk on a variety of subjects. So, but we just continue to plot on open enrollment for us for Medicare Part D prescription drug plans, and everything that goes along with that starts October 15th through December 7th. So those of us in the SHIP world will be nose to the grindstone. We're doing a few things in person, but most of our stuff, I think, is going to be done virtually again this year because of the soaring numbers. So we just kind of go with what they tell us, and we'll tell them when we're coming, if we want to do it on the phone or we want to do it virtually or we're going to do it in person. So, but I know that the call center is working hard and we're working hard to train our volunteers and get everybody ready for that, and including information about fraud and abuse in that as well. And Nancy, thank you for your update about the monies and the things about Medicare, about trying to get the dental, vision, and hearing. How long have I been hearing that? I've worked at SHIP since 1989. And I mean, 1998. And I mean, that's the one thing. Is Medicare going to pay for my dentures? Is Medicare going to pay for my hearing aids? Medicare going to pay for my x-rays? Medicare will pay for this? I mean, you know, those are services that we always tell people to weigh those services to see if they think that it's appropriate. If you've got to pay an extra fee for that, you've got to calculate that out and then look at what your limits are that they pay for certain things. So, you know, that just see if it's a good investment of your dollar to be able to pick up something of that nature. But as John and I always say, we are you know, available for weddings, bar mitzvahs, birthday parties, whatever you would like for us to come and talk to. And our services are free, confidential, neutral, objective, and unbiased. And we are there to talk about anything that we need to talk about with our partnership and the wonderful work that everybody does. It takes a village, people. I know that's overused and oversung, but it does take a village. And every person on this call does the very best that they can to promote elder abuse, stopping elder abuse, and awareness.
Thank you. John, anything you want to add?
Nope, I can improve on that. The only thing I can say is that the only event in which is truly unbiased are ones where Stephanie Bias isn't presenting.
Good one.
We always
All
play
right.
on my name, you know?
Yes. We're going to move along to the Communications Committee. Laura Slobach, Autumn Cox, and Allison Crossman are the co-chairs. Would one of you like to give us an update?
Sure. Hello, everyone, and thank you for staying with us. My name is Allison, although it says Kevin, I'm filling in for him today. But just a brief update. Please continue to check the website. Autumn does a great job maintaining that and checking your emails for any membership updates, including meeting links and important things like that. One brief update that we would like to share is we are working on our social media presence. So our main goal for the remainder of this year and next year is to be more active on our Facebook page. So if you haven't already, please visit us on Facebook and like for the latest and greatest updates. Thank you.
Thank you. Next is our membership committee. Kevin is not able to be here today, but I know he wanted everybody to remember that it was time to get membership information back into us along with your checks. Your membership helps support the partnership and all that we do. And we're already working on our conference for next year, as I know Tadra would say. Tadra, are you able to join us in person yet? I mean, unmute.
Yes.
Good, thank you.
All right. Can you hear me?
Yes. Yes.
Sorry. I feel like I'm always having audio visual problems. Yeah, so as far as our conference is concerned, there's a few things that we wanted to talk to the committee about. One is doing a hybrid one-day conference, a hybrid model one-day conference. Right now, we've talked to Wake Tech about having an in-person conference there on their southern campus from May 17th and May the 18th. Right now, Wake Tech is they have a tentatively scheduled for those dates, but right now they're saying they're not doing anything firm until the springtime regarding COVID, and even I think they're not taking any external reservations from people right now due to COVID, and even internally they're only I think allowing 25 people. But we are penciled in for the 15th and 17th of 2022. And our contact there said they hope that they would let us know more about mid-December how things will go in the spring. So that is on the whatchamacall. So that's that. But also we have met and talked about having this hybrid model. because, it's our belief that, with COVID, everybody has gotten used to being able to do these things virtually. So we thought it would be a good idea to have a virtual conference and an in-person conference for those who want to come in person. And so that's where the hybrid model came in. And we talked about some of the logistics of that, of having them being done simultaneously for those who are virtual, those who are in person, and we can talk about those details if you like. But also, just given the hybrid model, we were thinking that it may be best or easier to do a one-day conference. And so also with the one-day conference, we toyed around with some different topics and things like that. So also we plan to send a survey out to the whole membership list about topic or conference ideas along with the ideas that we have. So I think one of the ideas that we had is to have kind of these mini sessions, if you will, these mini sessions, and have them being led by people, the actual decision makers at the state level and at the state level regarding, for instance, with the NC Hope program, having someone there who can talk to you about the NC Hope program and exactly what you need to tell your clients to do to submit a successful application so it can be approved as quickly as possible. So having those type of mini sessions versus having maybe more of like a skill-based conference where people come and learn about different skill sets and how to expand their skill sets. So I think that's it. I may have went a little fast, so if you have any questions, let me know, and I'll try to answer them, because I know I probably dropped a lot at one time.
Thank you, Tadra. We appreciate it.
I have a question. This is Nancy. Tadra, do we know what the November, I'm sorry, did you just say that? I was doing something else.
Yeah, thank you. Also we need, regarding anyone have any speakers for the November meeting. Thank you for reminding me, Nancy. I forgot to mention that. I had it on my list, but I forgot. But yeah, so also if anyone has any ideas for any speakers or topics for the November meeting.
Yeah, please put it in the chat. Yeah, we need to. Yeah.
Thank you. All right. We were looking to see if any of the attendees, members, had anything to share or any updates they would like read. I don't see any response right at this minute. So maybe we could wait just one more minute and see if anybody has anything to share. I want to thank all of you again for attending today. I thank Chevelle for giving us a wonderful presentation. And as always, I want to say that the North Carolina Partnership to Address Adult Abuse is working hard to try and get the word out about adult abuse, neglect, and exploitation in all different manners, in all different ways, using all of our members. And so you are important to the membership. And if any of you have any upcoming dates, functions, speaking engagements you think the partnership might like to know about, we'd certainly like to hear from you. I see Heather Burkhart has said with the Coalition on Aging, hey Heather, has said that you can still sign up for the North Carolina Coalition on Aging annual meeting next Friday, and she's provided the web address in the chat box. So if anybody hasn't registered yet, they've got some great speakers coming up. So there's a lunch and a meeting. So thank you, Heather, for that. Anybody else? Well, I don't see anything else coming in. So can we get a motion to adjourn?
I will so move.
John Marin, second.
Stephanie, second.
Stephanie, second. Thank you. Thank you all so much. We'll see you again November 17th. Thank you.